Hello, my name is Daniel Clark. I'm a physical therapist assistant, and this is a case study in the rehabilitation following the surgical repair of a slipped capital femoral epiphysis, or SCFE. Remember those days when you were a kid, outside playing on a scorching hot and humid day? You hear the ice cream truck and run to your mom for $1 so you can get an ice cold treat. The truck stops, you wait in line behind all of your friends to make your choice, and finally get that snow cone. You open it, sweat dripping down your face, and take that first amazing bite of frozen relief. Then it happens. You move wrong. The heat melts the ice cream, or a friend bumps your arm. That sweet, frozen, heat-relieving goodness is gone. The ice cream slides off the cone, and it seems like your world has come to an end. Now you will be sweaty and tired forever, and you will never get over the heartbreak. Now imagine that the ice cream cone is your femur, and the ice cream is the femoral head at the proximal end of the femur. That is exactly what happens anatomically when a child suffers a slipped capital femoral epiphysis, or SCFE. The femoral head actually slides off the femur at the growth plate like ice cream off of a cone. This condition is most common in boys between 12 and 16 years old and girls between 10 and 14 years old, and it occurs more often in boys than in girls. The condition causes the femoral head to slip off the neck of the femur at the epiphyseal plate. Patients will often complain initially of stiffness in the hip that resolves with rest. Progression of the condition includes a limp as well as pain, most often in the hip. However, in approximately 15% of cases, patients report no hip pain whatsoever, but rather thigh or knee pain. Patients will often refuse to bear weight on the affected hip. It is an idiopathic condition, but childhood obesity, family history of SCFEs, and an endocrine or metabolic disorder are all risk factors that can contribute. This condition is diagnosed by careful study of radiographs combined with observation about patient's body type, recent growth spurts, and gait pattern. Patients will often display an antalgic gait pattern with a positive Trendelenburg sign for a unilateral SCFE, or waddling gait for a bilateral SCFE. Following diagnosis, the condition is classified either as stable or unstable. Regardless of the classification, the surgical procedure is similar. The preferred treatment is the use of an in situ fixation involving a screw or screws to secure the epiphysis. The unstable SCFE is treated in the same fashion but approached with an open incision, with the surgeon manipulating the head of the femur to its normal position before inserting the screw. However, the rate of osteonecrosis can be as high as 20 to 50% in patients presenting with an unstable SCFE. Some patients who may be at higher risk for developing SCFE on the contralateral side. In this case, a surgeon may recommend placing a screw into the unaffected hip to reduce the risk. Complications following the surgical repair of a SCFE can include avascular necrosis, which is death of bone tissue due to lack of blood supply, and femoroacetabular impingement. Both of these complications can lead to early onset osteoarthritis. Chondrolysis, a degeneration of the cartilage in a joint, may develop and lead to bone-on-bone articulation. Our case description: our patient is a 13-year-old female who was referred to physical therapy 2 days status post left hip capital femoral epiphysis repair. Patient was slightly overweight prior to diagnosis and surgery and was very active and involved in volleyball, softball, and cheerleading. Patient arrived to therapy on crutches due to weight-bearing restrictions and presented with swelling at the surgical site, high levels of pain, approximately 7 out of 10, and limited range of motion in all planes. The normal arthrokinematics of the hip allow for a fairly large amount of range of motion, but it sacrifices additional range for stability. Depending on the action, open or closed kinetic chain, determines the type of roll and slide. In open chain activities, the convex femoral head rolls and slides in opposite directions on the fixed acetabulum. In closed chain, the concave acetabulum rolls and slides in the same direction on the fixed convex femoral head. Range of motion of an unaffected hip joint are as follows. Flexion is approximately 120 degrees with 15 degrees of hyperextension. Abduction is about 45 degrees, and adduction about 25 degrees beyond the return to anatomical position. Internal and external rotation allow for about 45 degrees each. The force couples at the hip include hip flexors and extensors, abductors and adductors, internal and external rotators, as well as a combination of some or all depending on the movement of the limb. Following the procedure, the patient was placed on strict weight-bearing precautions of about 45 to 50 pounds and supplied with crutches. Initial PT evaluation showed patient with the range of motion in the affected hip of about half normal range, and all end fields were empty secondary to high levels of pain. The rehabilitation principles for recovery from SCFE initially involved moving from passive range of motion to active assist range of motion and finally to full range, active range of motion. Following increase in active range of motion, the patient was progressed to strengthening exercises in the affected limb. This was performed to prevent the patient from developing compensatory patterns in the lower back and contralateral limb that could eventually lead to other musculoskeletal issues in the future. The patient was gradually progressed in her weight bearing as long as she was able to tolerate doing so without reporting or displaying any signs of pain. As weight bearing tolerance increased, balance and proprioception activities were included to ensure that the patient was able to ambulate without displaying any type of altered gait pattern. The phases of rehabilitation. Phase 1 of rehabilitation consisted mainly of protecting the area of the repair to allow for soft tissue healing. Pain and swelling was reduced with the use of cryotherapy, and patient was educated to monitor for adverse reactions. Patient was educated in bed mobility and proper transfer techniques. Weight-bearing training with the use of a scale to get the patient used to the amount of weight allowed on the affected limb was initiated. The patient's crutches were also fitted correctly to ensure comfort and prevention of shoulder and back issues. Gait training with crutches was initiated with 3-point gait pattern. Stair training was provided to ensure proper technique of ascending with the unaffected limb first and descending with the affected limb first. Patient was also provided with low impact therapeutic exercises like ankle pumps, quad sets, glute sets, and heel slides along with frequency and duration of each. All were performed within tolerable range of motion and pain threshold. Phase 2 consisted of similar activities as Phase 1 but with some progression. Treatment consisted of passive, active assist, and active range of motion within tolerable ranges. Supine exercises consisted of ankle pumps, heel slides, hip abduction and adduction, hip internal and external rotation, and flexion return to neutral activities. Strengthening consisted in this phase included quad sets with full knee extension, glute sets, short arc quads, bridges within tolerable range, seated ball or towel squeezes. Visits concluded with about 10 minutes of cryotherapy to manage pain and swelling. Criteria of minimal pain and swelling, ambulation with assistive device without pain or gait deviation, and can perform daily home exercise program required to advance to stage 3. Phase 3 increased progression of activities in phases 1 and 2, as well as adding stationary bike for warm-up before treatment. Core stabilization activities were initiated with focus on transverse abdominals. Three-way hip and closed chain weight shifting activities, including sidestepping, were initiated. Balance exercises, including single leg stance with eyes open and closed on uneven surfaces, began around week 6 once weight bearing was tolerated by patient. Other exercises included lateral step up and down and forward step up and down, both with eccentric control. Gait training, as well as continuing the use of cryotherapy if needed for pain and swelling. Once the patient displayed minimal pain and swelling, ambulation without assistive device, without pain or deviation and good voluntary quad control, they were progressed to phase 4. Phase 4 is a progression of the previous 3 phases by increasing the number of repetitions and the resistance used in strengthening exercises. Trunk and core stabilization activities were progressed, and forward lunge and squat activities were incorporated into therapy. Balance progression included the use of Bosu ball or wobble board with ball toss and/or perturbations. Patient was instructed to incorporate increased ambulation distances, progress biking, and incorporate swimming, if possible, into her home exercise program. Patient was discharged at this time as she did not report or display any pain with ADLs. She displayed MMT scores greater than 4 out of 5 throughout the affected limb and was adhering to her home exercise program. During a follow-up phone call with the patient's mother, we were informed that phase 5 was initiated at about the 4.5-month mark after the patient was able to begin jogging and performing more intensive aerobic activities. The patient was cleared by her surgeon and PCP following multiple follow-up examinations to determine that the repair was effective and the patient was healing and progressing ahead of schedule. The outcome and conclusions of this case study: in a follow-up phone call with the patient and the patient's mother, we were informed that the SCFE repair was 100% effective. After 1 year, she reported no pain or range of motion limitations. She was permitted to gradually return to playing volleyball and softball and had just been given clearance for full participation in those activities with no limitations or restrictions. Her cheerleading return was being paced a bit differently, as she had been one of the supports for the pyramid, and the surgeon did not feel quite comfortable allowing her to support the weight of others just yet. It was also reported to us that the patient was remaining very active and making much better choices in her diet. In the following year, they informed us that she had lost about 15 pounds and was keeping the weight off. At the time of the phone call, the patient had not developed any complications following the repair of her SCFE. However, the complications discussed in this case study are most often seen later in life, and we will not know if she has developed any arthritic issues. And references: